Good evening, everyone. My name is Celine Gallagher, and I'm the Scientific Chair of the Australian POTS Foundation. Joining me this evening is Claire Seeley, who's the CEO and founder of the Australian POTS Foundation. On behalf of the Foundation, I welcome you all to our POTS for Practitioners webinar series, with tonight's presentation focused on exercise physiology for the moderately impacted and bed-bound dysautonomia patient. I would like to begin by acknowledging that we are hosting this webinar from the lands of the Kaurna people. I also acknowledge the traditional custodians of the various lands on which you all join us from today, and the Aboriginal and Torres Strait Islander people participating in this webinar. I pay my respects to elders past, present, and emerging, and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of Australia. We are fortunate once again this evening to have exercise physiologists Caelum Schild and Jacqui join us today. Caelum and Jacqui will commence their presentations soon. At the conclusion of the presentation or throughout, we invite you to submit any questions or comments you may have through the Q&A button at the bottom of your screen. And we will endeavour to get through as many of these at the end of the presentation as we can. Please note that this webinar is being recorded and will be available on the Australian POTS Foundation website for viewing at a later date. Without further ado, I'll introduce our speakers this evening. Caelum is an accredited exercise physiologist with over 12 years of experience working in various clinical settings, including in hospital rehabilitation, private practice, and within GP clinics. Drawing on over a decade of professional and personal experience with invisible illness, he now runs his own business in Adelaide, delivering exercise physiology services specifically for people with POTS and dysautonomia, ME/CFS, Ehlers-Danlos syndromes, long COVID, and other invisible illnesses. Jacqui has worked as an exercise physiologist for the past 17 years, 15 of those living with invisible illnesses, and hence her passion and dedication to these illnesses. Jacqui has worked in the hospital setting early in her career for 6 years, treating road trauma patients, university lecturing, always involved in sport herself at a high level, and worked in football clubs for 17 years before retiring this role when she had her first child in 2019. Jacqui has also worked in occupational rehabilitation for 6 years, corporate health and wellbeing, private practice, and now has her own business, Dizzy Heads & Co., focusing on her passion of Ehlers-Danlos syndrome, hypermobility spectrum disorders, and the comorbidities of autonomic dysfunction syndromes, long COVID, pain syndromes, ME/CFS, and mast cell activation. And Jacqui also runs a private Facebook group for people wanting to start a family, providing support for pregnancy and postpartum care when living with these illnesses. Thank you, Caelum and Jacqui, for joining us this evening, and I'll hand it over to you.
Thank you, Celine. Okay, so I will share our screen to get started, and hopefully it all goes well. Can we see that okay, Caelum? Yep, all good. So welcome everybody. Thank you, Celine and Claire, for having both Caelum and I tonight. So yeah, we're very excited to present on this very challenging area of movement, as we like to call it, or exercise in this population. So Caelum and I have previously presented on dysautonomia assessment for the allied health professional, which is on the Australian POTS Foundation website. Just if anybody would like to look at the thorough initial assessment that we like to complete in this population. I guess we don't really need to cover too much here, as Celine did an amazing job at introducing both Caelum and myself. We both have our own businesses. We're very passionate about the area that we work in, and that's because we both live with the invisible illnesses ourselves.
Yeah, thanks, Jacqui. It's great to be here this evening, and thank you again for Claire and Celine for having us present. It's fantastic opportunity again to be back chatting about this really important topic, I think. So a few learning outcomes for this evening. So we've got ideally this evening aiming to help people understand what the current evidence says. And how you can apply this to help patients, and how we can identify the impact of other life factors as well that are so crucial in this area. How to use heart rate variability, which I know is a common topic of query for a lot of patients and practitioners. How to approach prescription and progression of exercise, and then how to provide appropriate heart rate guidance as well. So as a current overview of the evidence, the nature of conditions involving fatigue makes it incredibly difficult to conduct rigorous RCTs. As such, the current management guidelines are compiled through theory, best clinical practice, and the little amount of research that has been conducted in this area, most of which do have quite small sample sizes. So some common medications used for POTS, although I guess most of us attending as allied health professionals were not able to prescribe medications, we still, I think, need to have a good understanding about these medications and how they impact our patients. As I like to run through with patients, for every non-pharmacological intervention, there's a pharmacological equivalent. So if we think of something like blood volume expansion, where salt and water is the non-pharmacological intervention, and exercise can help to improve blood volume as well. Florinef or fludrocortisone would be the common pharmaceutical intervention. Likewise, if we think of vasoconstrictors, which help with venous return, compression and exercise again can assist with this, but the medication equivalent would be midodrine. Then things like heart rate inhibitors. So one of the common ones that we typically see is ivabradine, and this is typically effective for up to 6 hours versus something like beta blockers, and in particular propranolol, which has got a fairly short half-life, sort of effective for up to that 4 hours. Typically, we'd need to watch for hypotension in people taking beta blockers, whereas with ivabradine, it's less of a concern. One consideration that I often take into consideration for each individual is how medications are important to consider when discussing appropriate times for movement. This could also incorporate things like ADLs, such as showering, especially in people who are moderately impacted, to ensure adequate medication coverage. So we'll go on to the next slide, and over here we've got a nice central illustration from the JACC series, which was published on POTS a few years ago now. And it gives us a good visual representation of typical non-pharmacological interventions that can be used to help orthostatic intolerance symptoms. So touching on things like temperature and alcohol and food, through to salt and water, and through to things like compression and physical counter maneuvers, and then the exercise. So first of the non-pharmacological interventions for POTS, considering, and this is quite relevant to exercise and movement, just from a blood volume component. At the absolute minimum, one of the aims that I initially get people to work towards is having sort of the equivalent of, or half a teaspoon of salt with 400 to 500 ml of water in that first hour after waking. And sometimes this has to be a process to get towards that amount because it's not always well tolerated. Ideally, we'd use a similar approach within that 60 minutes prior to performing some movement or exercise as well. Just so that, again, we've got that coverage of blood volume there, so that when we do start to perform some movement, particularly if it's slightly recumbent or a bit more upright than what that person is used to, that they have more likelihood that they'll tolerate it well. So this particular study, they found in POTS patients a high dietary sodium intake was far improved plasma volume and lowered the standing plasma norepinephrine as well. And it also led to a decreased delta heart rate, or a change in heart rate, on average 14 beats per minute. So if we go on to the next slide, we've got compression, and typically the compression component is recommended for POTS and a grading of 20 to 30 millimeters of mercury to achieve sufficient stroke volume. Although movement in itself does assist with that venous return, having compression on just prior to, during, or immediately after the movement can assist that exercise tolerance. And as you can see in the chart on the screen, we do see a substantial improvement in that delta heart rate with full compression as well. Again, though, looking at those error bars, you can see some people don't necessarily respond well to the compression. A few notes on the compression. So ideally, it does work most effectively with high-waisted garments, so the lower limbs and the abdomen. But certainly in my experience, not everybody tolerates the high-waisted garments due to abdominal discomfort. And so we often do to resort to lower cut garments. Then I guess if we think of situations like summer or periods of time where having some coverage over the thigh plus the abdomen could be an alternative to full length, just to strike a balance between temperature regulation and compression. A couple of common brands that do rate their garments on their websites include Supercore, so it's SUPA Core, and 2XU. They actually have ratings if you go onto their website for different garments. And we've also heard some good reports of Amamico, but they don't have ratings on their websites of their garments. Another note for the health professionals out there, some people may even be eligible for rebate on these through their private health fund. It does depend on the fund, obviously, but that's something just to consider for people as well. In terms of looking at this particular study, the study findings were that the effects on orthostatic tolerance were driven through improved stroke volume from the compression, and abdominal compression alone might also provide a clinical benefit if full lower body compression isn't tolerated. So then on the next slide, we've got some physical countermeasure manoeuvres. These can have a profound impact on optimizing venous return, and commonly for people who may be bedbound or moderately impacted, it can be a good starting point for some adequate movement. And if we're thinking of most common counter maneuvers that we can implement, things like glute squeezes in a seated position, a seated calf raise, crossing your legs and changing frequently, a seated hip adduction, so a pillow squeeze, or an seated isometric abduction even could be used too. And from a standing side of things, tensing those thighs and glutes, crossing one leg in front of the other, and frequently changing the weight from one leg to the other as well can be quite useful. So moving on to the exercise side of things. This is going back to a study that was initially done in 2010 which really, I guess, kicked off a lot of the research into exercise and movement in the POTS community. The initial study was, again, as you can see, quite a small sample size and completion rate around the 76%, so about 3/4. And it's important to note that this particular intervention was done fully supervised by EPs, so they were actually able to modify and encourage and adapt sessions to the participants' capabilities. The findings, the study findings, were that all participants experienced a reduction in heart rate, and interestingly enough, 53%, so a bit over half, no longer met the criteria for POTS at completion. And you can see that in the chart on the left-hand side of the screen. So then this was followed up in more of a real-world simulation a few years later, and it was done over a 3-month period of time. So, and as you can see, probably the thing that highlights to me significantly in comparison is the significantly lower completion rate. So less than a half of people were able to actually complete this study. In their discussion when writing up this paper, the George and colleagues made mention to people having to self-administer and self-monitor their activities. So at times when things may have gotten a bit too challenging or a bit too complicated, or people weren't quite sure what to do, oftentimes they would withdraw from the study as opposed to having someone there to be able to help support them through. And I think for me, that's one of the big opportunities that we've got as health professionals, in particular, EP, physio, OT, even, where we've got the ability to help people through and adapt and use the skills that we've got to be able to help adapt the movement intervention to meet the patients where they're at, and to kind of balance that implementation with adequate movement versus the amount of energy that each person has available as well. On the next slide here, we've got, I've just done a bit of a summary of the various different protocols, because it's something that if you do a Google search or a search on Google Scholar, for instance, on protocols for POTS, you'll tend to come up with one of these three. And they're all kind of variations of a very similar thing from those studies that were just on screen previously. In my opinion, they're an okay guide. Again, like I sort of mentioned before, they are largely too difficult for the moderately impacted and bedbound patients, of the people that we're speaking about this evening. And ideally, as health professionals, we need to be able to modify and adapt them so that we can meet the individual needs of our patients by personalising a pacing and movement program to optimise that effectiveness and the safety as well. So working with these patients, if we can adapt the movement plan to suit an individual's ability, is crucial, because everyone will have unique circumstances and require slightly different management techniques and focuses. And I think it's especially important when beginning a movement plan, being able to identify and then work within someone's tolerable limit, which we'll touch on shortly. And then no matter how the exercise is modified, because it's a new stimuli for the autonomic nervous system, there will be an element of difficulty initially, but recognising that, and it's very different to experiencing days of post-exertional malaise following that activity. And then as people tolerate exercise or movement better, we can help with those very small progressions. And that's something that we'll discuss in detail later on as well. So I'll pass over to Jacqui now.
Thanks, Caelum. Yeah, so as Caelum was just talking about, is that, you know, a lot of those programs can be very successful for what we would call kind of a straight POTS or a straight orthostatic intolerance. And We have seen that before because essentially this is without a lot of the comorbidities that go along with these conditions. And one of the biggest ones is fatigue, or ME/CFS. So we thought, I have a lot of patients that, have been through what a lot of patients have been through, where there's years and years of seeing health professionals who may or may not have understood what has been going on with their health. And yes, they may have been diagnosed with POTS or orthostatic intolerance or dysautonomia. And then because of the fatigue, they say, oh, well, should I get a diagnosis for chronic fatigue syndrome? And my answer a lot of the time is, well, what difference is it going to make? Fatigue is fatigue. So I guess in my next couple of slides, I want to differentiate, well, what is fatigue and what is ME/CFS? Because I guess, same, but maybe a little bit different. So there's been a paper published by Dr. Alan Hakim, who is an amazing rheumatologist in the EDS world, so what is fatigue? So fatigue can be temporary, categorized as recent, prolonged, or chronic. So it can be 1 to 6 or more than 6 months. We want it to be obviously persistent, and it impacts on our daily activities and quality of life. And that's kind of more of our descriptors of chronic fatigue syndrome and myalgic encephalomyelitis. So the evaluation of chronic fatigue in EDS, POTS, etc., needs to include quite a careful clinical examination, laboratory testing to exclude other issues that can cause quite significant fatigue. And most of these may be along the lines of thyroid conditions, celiac disease, iron deficiency, etc. So we want to make sure that we're ruling those things out as well. So chronic fatigue, so defined by persistent and or recurrent fatigue that's been present for more than 6 months, unexplained by other conditions, not the result of ongoing exertion. So this is a big thing that we see in a lot of our patients, is that it doesn't need to be a huge physical, mental, or emotional event that leads to fatigue. It can be somebody receiving a phone call, that they've read an email that's been quite triggering, they've eaten the wrong food, and it can cause quite significant fatigue. So this is where we look at the depths of what our patients go through, which we'll explain a little bit later, in terms of what's contributing to somebody's fatigue. It's not substantially alleviated by rest. So essentially with fatigue, and we often need to go through with our patients, is what's the difference between tired and fatigue? Because tiredness is usually due to, well, we haven't had enough sleep, and usually sleep will fix that. But fatigue, well, it's not alleviated by sleep or napping. Otherwise, a lot of us wouldn't have jobs, because people could just sleep it off. So there usually needs to be more than just rest. And for a lot of the POTS population, resting is actually not conducive to what they're feeling, because if we're still for too long, that can make us feel pretty lethargic and horrible. If we're upright for too long, same thing. If we're up and about for too long, same thing. So it really is a very definitive balance. So yes, fatigue is obviously resulting in a very substantial reduction or impairments in the ability to engage in our normal level of activities. Whereas ME/CFS, and I have always really liked the Canadian consensus criteria, bit of a tongue turner. So the CCC definition in that it includes the cluster of fatigue and malaise that's worst after exertion. But what I like about this definition in particular is that it does include the cognitive dysfunction, immune dysfunction, unrefreshing sleep, pain, and autonomic dysfunction, as well as the neuroendocrine system as well. And that's often what a lot of us see in all of these patients. It's not just fatigue or just POTS. There is so many different systems that are impacted by this. So the NICE guidelines were refined and brought out in 2021, and they have clearly documented that ME/CFS is obviously very complex and it's chronic and it affects multiple body systems. It affects everybody differently. Like Caelum said, there's not one patient that we see day in and day out that is exactly the same, and that's why everybody needs to have a very individualized treatment. It is very fluctuating. So we have good days and bad days. And as I say to a lot of my patients, is just because you have a good day does not mean you can go and do more, because that will often lead to the bad day. So it's very hard to, I guess, control when people are having a good day, because as much as we want them to enjoy that, it's often not a long-lasting thing, and we want that to be a long-lasting thing. So yes, very fluctuating, and not only does it affect the individual themselves, it's their family, their friends, employment, and all of those sorts of areas of life. And what has become, I guess, a bit of a, as I would say, a swear word over many, many, many years. But I guess it depends on how we approach, movement or exercise. And that's why we use these words interchangeably. But in accordance with the NICE guidelines, is graded exercise therapy is a term used in varying ways by different surfaces to support people with ME/CFS. And the biggest thing is that stands out, and when I reviewed it myself, is that the only thing that was really outstanding was it making fixed incremental increases, which we know even for those of us without an invisible illness, is that there is no one day or 1 week that is the same as the next. So, being able to progress by a certain amount by, day or week is quite unpredictable, and we shouldn't really be doing it. So this is what they really wanted to blanket out in terms of the term graded exercise therapy. I'm involved in a lot of forums and different things, and it still does get thrown around that is very dangerous and life-threatening and all those sorts of things. But in my own personal opinion, whether we call it graded exercise therapy, we can make it very safe for a particular individual. So the definition of graded exercise therapy in regards to the new guidelines is an approach that they say should not be undertaken. So it's a very thorough and a very good guideline if you would like to go and search through that a little bit more yourselves. So as we all tend to do who are specialised in this area, is it is very personalised, and we do plan for areas of energy management, which we're going to go through a little bit later. And this is the importance of, rest and different types of activity to stay within somebody's energy budget. But then obviously in terms of progressing that, we want to be able to push those limits very gently and very slightly when somebody is managing. And it is also that, like we would think if, any of us were to start a new job, have a baby, start a new exercise regime, it's Friday after a busy week, we tend to always have a feeling of exhaustion. So we want to also normalize that. And I often talk to my patients about that as well, is going, well, even somebody without an invisible illness may experience, exhaustion at the end of a week. So we can often start to, it's not, what's the word? We're not discrediting or anything what they're saying, but there really is a way of making sure that we can understand, well, what is truly in the realm of an invisible illness versus, well, what have we, forgotten about exists. And I know myself, 16, 17 years down the track, I don't know what it's like and what it would be like after a busy day of work compared to what I do now. So some very good things to be able to look into. So how can we apply this evidence clinically from what Caelum and I have just spoken about? So there really needs to be some thorough education behind what we are doing with this patient population. And this is something that we've navigated ourselves over many, many years. And often this is where sometimes things can maybe not go so well, is that people might come to physio, OT, exercise physiology, personal training, and because that's what we're used to doing is prescribing exercise or rehab or whatever it might be, but that person might not actually be ready for any sort of movement or exercise. So a lot of our approach from where we sit as specialising in these conditions is a lot of our approach is education first, because a lot of our patients have met numerous health and medical professionals who haven't actually been able to explain the in-depth knowledge that they need to be able to manage or control their conditions. So these are a lot of the topics that we will tend to go through. So very gently approaching the neurophysiology of their conditions, talking about the demands of their activities, and that's where we'll use a variety of tools, which Caelum's going to talk about shortly. I'm going to talk about pacing and what that is, movement, depending on what the individual has experienced, whether that's pain management, POTS management, talking about triggers. If somebody doesn't know what triggers a flare-up of symptoms, then they're not going to be able to ever avoid or control the exposure to those. And what we also love to do is going, well, when you feel terrible, we want you to know what to do, because rest is not always the answer, particularly with POTS, as I mentioned before. Sometimes it may have been that you've rested too much and physical activity is actually going to help you feel better. But we need to ensure that they're going to believe us that that is going to make them feel better. Goal setting, graded exposure, sleep disturbance is a huge thing in this population as well, because if our autonomic nervous system is not working properly, then we've got a lot of adrenaline that tends to try and control our heart rate, blood pressure, etc. And hence we need to try and include some relaxation and parasympathetic activity. Mindfulness, body stress response, we tend to talk through a lot with these patients, because it's so POTS and its use of adrenaline, and then anxiety and stress, and then we can get stressed and anxious about feeling stressed and anxious when we're not stressed and anxious, because that's actually POTS doing its thing. So that's a huge big whirlwind that a lot of patients go through, and they always have a bit of a cackle when we explain that, they're actually not anxious. For those of you who are familiar with the DIMS and SIMS analogy from David Butler and Lorimer Moseley, created in the pain world, but so applicable across all of these illnesses. And we will obviously help anybody in terms of return to work, school, whatever it might be. We know that the hormones and the menstrual cycle impact the female population quite a lot. So we help with that, and diet within our scope of practice. So moving on to the exercise therapy side of things, this is a diagram that I draw for all of my patients to really get them to understand why I bang on about pacing for so long. So pacing is our foundation. If we do not have a stable base and a baseline, we are not going to be able to successfully implement and manage movement or exercise, our sleep, managing stress and anxiety, good nutrition, implementing our strategies, and depending on, the particular person's, goals and what they are doing, whether it's work, study, parenting, social connections, whatever it might be. If our pacing isn't solid, our pillars are wobbly. So we're not going to be able to successfully implement these. And our roof is made up of those DIMS and ZIMS. So we want to try and identify, what are those things in our environment and in our life that might, start to leak through into our pillars to also make them unsteady, because I've seen a lot of patients who can pace absolutely beautifully and we've got some good strong pillars, but there are those things that, from a threat and danger in me perspective that just leak through into these pillars, which can make them a little bit weaker. So we want to strengthen a lot of our SIMs, which is that safety in me. So activity diaries. I guess a lot of the people that I come across that tend to be perfectionist, high achieving, really caring, really giving. We know there is, an element of those that I meet. So ADHD, ASD, and they love these. And then there are those who I hate them. So an activity diary is the way we will figure out when somebody is ready for movement or exercise, or if they are already doing some movement or exercise, we can see whether that is contributing to particular boom or bust patterns. So this is a patient's diary I have had permission to share. As you can see, I get my patients to include absolutely everything they are willing to share with me, from diarrhea to constipation to periods to headaches to dizziness to everything, because majority of the time, and Caelum as well, so people who are really specialized in working in this area, is that every little symbol that represents a symptom, we can explain the why. So why did you feel that way in that particular moment? And or going, well, let's maybe not do that at that particular time. Let's do it at this particular time because of X, Y, Z. And or let's just not do that at all. So particular one, showering in particular. A lot of people don't like to do that first thing in the morning, even though, so on this Monday, the 11th of the 2nd, showering is green. So I get my patients to color code if they're up to it. So red is high energy demand, yellow is medium, green is low. And showering is green. Obviously, it's nice and relaxing, all of those sorts of things. But then, as we can see, after this, she went to the supermarket, and there was that little asterisk in the box where she was experiencing quite a bit of head pressure and some dizziness and vertigo and things like that. So we know that that makes quite a lot of sense. Following up a supermarket visit, lots of lights, lots of noise, walking around, head movement. So she actually had some vestibular symptoms as well. Following a shower, not such a good mix. but followed it up with quite a relaxing activity. So this is the thing, is also symptoms can happen, symptoms can occur, and it doesn't mean that we want our patients to avoid doing things. We can go, well, if we need to do things, or we've got an appointment, for example, we can buffer our activities with this green time. So we can start to conducively use and spare our energy as much as possible. Ratings at the start and the end of the day, super important. So somebody going from a 5 to a 4, fantastic. 4 to a 4, stable, fantastic. 4, 4, 4, 4, 5 to a 4, 4, 4, 4, 5. Like dream activity diary. And this is what we want to look at, is that even though she felt worse, you know, on and off during the day, we want to look at that overall part of it. And VRT is actually some vestibular exercises. So as we can see, she was able to achieve exercise throughout the day, go to some appointments, massage, some socializing, because she was able to try and create that pattern to her day. So yeah, where possible with this, once somebody has met me and we've done their initial assessment, we get a look at what their life looks like, we give them some advice, and then we can start to tell them, you know, how they can prioritize time, activities, and energy according to what's important to them. How it can be modified to make it a little bit easier. Shower stool. So I can definitely shower standing up, but I have a stool because that just creates a little bit more energy. My little boy likes to stand on it more than anything, but you know, wherever we can make a task easier, even though the person will feel like they do not need it, let's make them use it. Because if it's a little bit of energy that they can conserve for that social catch up on the weekend or whatever it might be, let's help them use it. And then forward planning. So forward planning can look like this. So this is obviously a higher level patient, but it was more just I wanted to give an overall look of what forward planning looks like. So putting things in ahead of time, color coding it ahead of time so that they know where to put more, you know, relaxing tasks. And we want a green list, for example, to be portable, because we all know when we go to a doctor's appointment or a specialist appointment, how long are we going to be sitting there for? So rather than sitting there frustrated and looking at the time, what are you taking with you? Where can you sit and put your feet up? Is there somewhere you can sit on the floor so that the legs are horizontal? We want that blood flow closer to the trunk. All of these sorts of things are really important to a POTS patient. So I'll hand over to Caelum now to talk about the levels of movement.
Yeah, so thank you, Jacqui. So once we do identify that people are ready for some formal movement, we can go through various different levels. And as we'll focus on in the next slide in a moment, we're going to be focusing mostly on sort of the 1 through to 3 this evening, just because we're focusing more on the moderately impacted and bedbound patient. From a formal movement program perspective, typically for people, it would tend to incorporate initially some supine or recumbent forms of activity. That approach ultimately allows people to perform movement while avoiding that upright position, thereby improving that tolerance of the program through more efficient venous return. So effectively getting better blood flow back to that right side of the heart, and then more efficient stroke volume essentially to perform that movement. I guess the way we can often think about this is being able to perform some movement which requires that light level of exertion without the stress of being upright. So to still give people that benefit of movement without having that immediate, much higher heart rate just upon standing. And that's something that we'll look to add some exercise. Oftentimes can increase that heart rate if we are upright. So on the next slide, here we've got just one back one, Jacqui, sorry. So we've got the three different levels here sort of that I wanted to touch on most of this evening. And I've got a few bits and pieces here, but for the purposes, I guess, like we said, of the webinar, we'll just focus on these three. Ideally, as a start point for people, if most of us as physios EPs will be familiar with a perceived exertion scale, RPE scale, and typically a good start point for people will be somewhere around that 1 to 2 out of 10 RPE, so extremely light. But looking from a supine exercise side of things, we could even start as simple as some isometric movement, which might look like some pillow squeeze or glute squeeze, quad squeeze. Then we could, the next level up from there, think of it like a sub-level, I guess, in terms of supine exercise. Things like some gentle dynamic movement, so ankle pumps, ankle circles, wrist circles, some leg slides, those sorts of things. And then again, that at a similar sort of level, some people may not get along real well with the strengthening component, so we could maybe look at introducing some gentle mobility exercises, things like some supine glute stretching or some supine hamstring stretching or lumbar rock, sideline quad stretch as well. One thing just with the mobility component to be mindful of is the overlap of hypermobility in this population group. So not to overly push that joint mobility, but more sort of aiming for that mild muscle stretching and to assist with the venous return. Then again, if we're thinking sort of that next step up or that next sort of sub-level, we could think of some more dynamic movements such as a straight leg raise, as you can see pictured there, a bridge hip abduction, so that sideline hip abduction, as you can see there as well, a sideline clam, or maybe even something like a modified dead bug. And then the next sub-level in that category, if you think about that, might be for some people that can tolerate an all fours position, is to perform some movements such as like a leg only bird dog, so a modified bird dog. Something like a thread the needle type movement can be useful as well, and things like a cat camel. This is sort of getting closer to that level of doing something like a very, very low level mat-based Pilates. But oftentimes in people, a starting point with these forms of movement will tend to be spread throughout the day rather than doing them in great big chunks. From a seated exercise side of things, we can look to incorporate some seated knee extension or some seated calf raise, some seated marching. And this is usually at the point as well where some people, we might be able to look at incorporating some recumbent pedals or exercise bike. And later on down the track, that recumbent component could even look at something like a very light intensity rowing machine. If just to touch on the pull-based therapy or the hydrotherapy component, so a couple of extra considerations there is just to have some really good preparation for people. So adequate fluid, electrolyte, salt preparation, frequent fluids during the session, if possible, see if they can be positioned near a vent or an open door, and potentially needing to modify that exercise further to be done in a recumbent position, floating on a noodle or a tube, rather than standing upright. And then the final thing is just to encourage them to get out of the water very slowly with some support, and maybe even have a chair there potentially as well at the exit. So on to the next slide, we've got a couple of considerations here, obviously, in terms of that movement initially is gauging what that intersession symptom exacerbation is, so making sure that we're not exacerbating things too much. But but also being mindful of that post-exertional malaise. And like we said before, it's that post-exertional malaise is quite different to just feeling a bit of, say, muscle tiredness or some tiredness having done some gentle movement. Ideally, we would like to combine some form of subjective reporting, so something like the VAS or the RPE scale together with an objective measurement such as heart rate. So heart rate variability comes up a lot with people that I see, and it can be a really useful tool. Ultimately, heart rate variability consists of changes in the time and the amplitude between consecutive heartbeats. So that's typically referred to as the interbeat interval. So as you can see here, those numbers in the circles are represented by the amount of milliseconds between each of the R intervals. So that's what we would classify as the time interval or the time domain. And the green hatched line, if you like, is the amplitude or the frequency intervals. And you can see here, this person has identical amplitude, but the time domain is slightly different. So on the next slide, we've got a little demonstration here. So we're hoping that this will work. It did when we trialed it before. So this is actually like a real-time heart rate variability recording that I took just as a screen grab. And you can see there the heart rate itself is not changing a lot, but you can typically see how each of those dots represents an RR interval. And then as I took a really big deep breath in and a really big deep breath out, you'll start to see in a minute that those RR intervals begin to lengthen out slightly on the out breath. So you'll see that coming up shortly. And then so that was just it there. And then on the in breath, they'll come right up. So it's quite a marked phenomena. And we can classify the normal changes, so not the big peaks and troughs that we're seeing there, but the normal changes as a normal respiratory arrhythmia. But we can also evoke more of that vagus nerve stimulation through taking larger breaths like that. So yeah, just hopefully a useful little screen grab to identify maybe a little bit easier as to what we're looking at with heart rate variability. So normal heart rate variability, and this is something that I get asked all the time as well. There's huge variance. So again, just throwing numbers around, and this does have heart rate variability. So primarily looking at the left side there, which is a time domain. As you can see, the average is, I don't know, 45, let's say for that's a male in the 25 to 34 year age group. But that normal variability is huge. So ultimately with people, rather than looking at trying to get towards a normal heart rate variability, oftentimes what I discuss about is how can we ultimately help someone's heart rate variability be a little bit more stable, so them to be able to respond a bit better and their autonomic nervous system to respond a little bit more appropriately to the stimuli that we might be throwing at that autonomic nervous system or the person in this context. So on the next slide, we've got a couple of review articles, so or one review article and one research article. The review article was done in POTS, and again, like we often see with different pathology, POTS patients have a much lower heart rate variability in terms of that time domain measure than healthy populations, and the same sort of thing was noted in that ME research as well. So if we go on to how we might be able to use this clinically, so in clinic, there's a couple of different ways we can use heart rate variability as a bit of an insight, if you like, to our autonomic nervous system and that preparedness for it to cope with stresses or maybe not cope with stresses on a particular day. So it can help with optimizing that pacing a little bit. each of these screen grabs here is a demonstration of what we would classify being a morning readiness reading, which is typically done in a supine lying down position upon waking each morning. Ideally, people maintain normal breathing. They might need to empty their bowel or bladder first. And this gives us a day-to-day comparison over an extended period of time as to where their autonomic nervous system is compared to their typical baseline measure. And then we can use that information to help guide that decision making. So we don't want it to essentially dictate exactly what we're doing for the day. It's just an objective measurement that we can use to help guide us as to, okay, I wanted to do X, Y, Z. That was going to be a little bit more demanding today. Maybe today is not the correct time to do that. I could do A, B, C instead as my plan B. The other way that we can use it clinically as well on the next slide is over a time frame. So we can look at the trend over time to see how someone's heart rate variability may be changing over a period of time. So that kind of zoomed out pacing view, not only in terms of a single day, but also over an extended period of time. And typically some things to consider are that the heart rate variability will always go up and down. Ideally, if we are aiming to minimize those peaks and troughs, or if there are some peaks and troughs, kind of knowing why they're there. So that trigger identification that Jacqui mentioned earlier on. And typically those greater peaks and troughs will tend to indicate more tendency to experience that boom bust or push crash cycle. And a more stable pattern relative to an individual will tend to indicate more optimal pacing. So it can give us a bit of feedback. It's a feedback tool. So some things that we can use for heart rate variability. So the gold standard really still is the polar strap in the bottom right-hand corner there, because it's using the electrical signals from the heart, but the reliability has improved dramatically with optical sensors. And to the point where they're, for most people, if you do like a cost use benefit, if you like, for a lot of people, they do often now come out on top for a lot of people in terms of weighing that up as to what benefit we can get from them from a guidance side of things versus how much it might cost or the accessibility to people. The most important thing, I think, if we're helping to guide patients with heart rate variability is to encourage them to pick one method. So either pick that morning readiness reading or pick the overnight measurement that your Garmin or your Fitbit might do and stick with that. Don't look to try and compare one against the other, because it can lead to a definite source of frustration and almost that over-analysing of some of the data as well. Yeah. I'll pass over to Jacqui and she'll talk about establishing that baseline.
Yeah, and exactly what Caelum was saying there is, you can create a bit of a spreadsheet to, look at, obviously date, what the exercise type was. For example, or you could put that as morning readiness score and see what that is, what their exercise type was. And with this population as well is whether it was a walk, whether it was sitting up on the edge of their bed for 30 seconds, whether it was vacuuming, whether it was going to the shops. We want to capture those types of movement as exercise, because that's what that is for this population. There is not always, exercise as per the definition that we would go to. We want to be able to look at, and what I get patients to do is if they've got a wearable or doing it via an app, is doing, we'll start and stop. What is the peak? What is the average? What's their borg? What's their shortness of breath? Whatever we want to put into this, it is this data that helps us also create an exercise baseline. So it gives that patient the confidence to go, well, you've looked at lots of different scenarios within my life that I do day in and day out. morning to night, and we're able to create exercise baseline. So a lot of the wearables and things like that, they'll give you, a maximum and an average. And then we want to be able to do, well, what is the average of the averages? As long as there's a good borg and shortness of breath and comments and everything that goes with that. And this is how we become confident in prescribing quite suitable exercise. When somebody wants to progress their exercise, I get them to ask themselves 3 particular questions. So how am I tolerating it? How have I been feeling? But most importantly, what's coming up in the next week? Because people can be feeling good, they're tolerating it, but then if they've got 5 appointments in the week coming up, well, if we go and progress their exercise because they're tolerating it and they're feeling great and they want to get more, well, that's where they're going to bust. So they're just 3 simple questions of reflection that I often like to get patients to do. When we are progressing any sort of exercise, we've got to remember that there are so many different variables that we're looking at. So reps, duration, frequency, intensity, or altering the exercise, adding a new exercise. So we only want to ever adjust one variable at a time, because we always want anything to do with movement and exercise in this population to be able to be kind of backtracked, and we know the reason why. As we go, okay, well, we adjusted that. Again, activity diaries and that analysis can be really important to go, well, it wasn't the exercise, it was the fact that you had a really bad night's sleep and you got a really stressful email the day before. So that already loaded and overflowed your bucket before we even got to the exercise. Let's try again in a couple of days. So we want to be able to give that confidence to our patient population. Exercise snacks, Caelum and I love this kind of a terminology, because often people get a little bit deterred by going, well, I don't have enough time in the day and exercise is bad, etc., etc. So if somebody wants to, they've got to get up and they've got to boil the kettle, they've got to make a snack, they've got to go to the toilet. Sorry, my kitten just fell off the table because she fell asleep. So we fit in movement around times which are surrounded by restful breaks. So, waiting for your heat pack to warm up, that might be 1 or 2 minutes. Can we do some mini squats or some heel raises whilst we're doing it? Some push-ups against the wall, push-ups against the cupboard, whatever it might be. So this is a really great way of spreading somebody's exercises across the day. And I love this terminology, exercise snacks, which was introduced to me by a patient. Again, the recordings is always really important. Exercise is not always the reason for a setback. So I'm just looking at this example of the 12th of the 5th. Comments, didn't feel hard. Why was it so hard? So the 12th, we can see really well-paced day, but what happened the day before? We can see lots of red, lots of comments around what was going on, but also the day before. So we've got to look at that 24, 48 hours. The accumulative triggers are often the reason for a setback, and they are the most perplexing for people to figure out. So this is why exercise records and some data and activity diaries can work really well hand in hand to give our patients that confidence that they need to keep moving forward in this area. Resistance exercises, very, very minimal compared to what we're probably used to prescribing. It might only start off as 1 set of 3, and we might only give them 2 or 3 exercises. And again, we've got to look at the different variables. So you're only going to progress a set, a rep, and I mean 1 rep, resistance, or add an exercise. So it's just that one variable at a time. finishing off, the next webinar, Pearls and Pitfalls of Special Diets in POTS. I've worked with both Luke and Mel, and that's going to be the next webinar run by the Australian POTS Foundation. So if you're wanting to know a little bit more about those gut upsets and dietary considerations around people living with POTS, then this is another one to register for. And now we can take some questions. I'll stop my share.
Thanks very much, Jacqui and Caelum, for a fantastic webinar. I think we've all learned a lot this evening. So we do have a couple of questions that have come through. So Caelum, one for you to start. Which program or device do you use to measure the heart rate variability that you've shown in the screen grabs?
Yeah, thanks. And Dion, I think is how I pronounce the person's name that asked the question. There's various different heart rate variability screen grabs that we can, or apps that we can use. A free app is called Visible. That is one that's been developed in specifically following long COVID. So it's quite relevant for POTS and for chronic fatigue as well. That's a free app. HRV for training is a paid app they've done a couple of validation studies on that as well. That's an optical sensor, as is the Visible. So you just use your phone camera. With HRV for training, it is a little bit more along the lines of fitness and those sorts of things. However, with all of those, it's up to us, I guess, as practitioners to be able to use that information to help our patients interpret what it's telling us. So rather than interpreting it as, I need you to do more exercise or less exercise, it's sort of in the context of nervous system and what that's telling us about that. With the Garmin and the Fitbit devices, if you've purchased one of those that have it built in, you'll get that come up if you wear it at night time. And the polar heart rate straps can be linked with Elite HRV is a free app. HRV for training can also link with a polar strap. Tory app, and I've probably missed a couple, but hopefully that gives them enough information on them.
I think there's a lot of options there. Needless to say, Caelum said to us earlier, he could do a whole session on heart rate variability. It's an area of great interest, and it's not simple either. So this is just a brief overview of this. There's probably a lot more for people to be gained from further exploration around that. Let's see if Celine's got another question there.
I do. So Josephine asked, can you please explain which breathing exercises can help with POTS?
So there, and this is where a couple of the apps, HRV apps, actually have so a biofeedback section in them. So I really love the Elite HRV app in particular, because they've got down the bottom, it's got biofeedback, and it can actually take you through a range of different breathing exercises. Caelum, I'm not sure, do the other apps have those as well?
None of the other ones that I'm aware of. Tory might. The other ones don't. It's just Elite is the one, because you actually need the electrical RR signal.
Yeah.
Yeah.
But I think across any sort of breathing that is, it's deep breathing, it's diaphragmatic breathing, our vagus nerve sits very much in, deep in our thorax, and any sort of diaphragmatic breathing. But what a lot of our patients find is that because they've been, real, what we call these apical breathers and upward, and we get this coat hanger pain, is it can be quite difficult to breathe, down into our diaphragm and our rib cage again for the first time in a very long time. So I would take it very, very gently. But the Elite HRV app, you wouldn't really have to have the chest strap to do the biofeedback exercises. So you could look at, but any other meditation app that does some really nice gentle breathing apps would be completely fine.
Great, thank you. Deb asks, are there any absolute contraindications in terms of type of exercise, specifically resistance exercises or overarm or overhead exercises that may be contraindicated in this population?
Yeah, we don't really want to put our arms over our heads. So like we see a lot of POTS patients, washing our hair, doing our hair, straightening, hair drying, anything. So anything over our heads can tend to cause an increase in tachycardia, drop in blood pressure. So I tend to ban that a little bit with a lot of my patients, because we want to make exercise feel safe and not exacerbate symptoms. So Caelum, have you got anything else to add to that?
Probably you've answered perfectly. Probably my only thoughts are, like, if you are looking at entertaining some overhead as a beginning, doing it in a supine manner. So therefore it becomes a position where it's a lot better tolerated in terms of venous return. We're not quite getting that blood having to come back to the heart and then go up to the arms as well. With all this blood pooling while upright, we can actually have a bit better venous return and a bit better delivery above head. And particularly if we're just looking at something that might be single limb above head initially, without weight, essentially, might be a start point if someone is looking to progress to that from a position where they weren't previously doing it.
Sure. Yep, great. Somebody has said you didn't mention the Apple Watch. Is there a reason for that?
Yes, yeah.
I was actually just replying to that. I'll say I have an Apple Watch and I've got nothing against the Apple Watch. So,
but I will say, like, so Apple Watch can link up with the HRV for training app. You can use the breathe function in the Apple Watch to take a HRV morning readiness reading through the Apple Watch. The issue with the Apple Watch, and the biggest thing that's difficult, so we can use it with, like, over a period of time. So you can use, say, it on the monthly or the 6 monthly view and actually see what someone's trend is like over time. But the issue with the Apple Watch is it will ping HRV readings at random times of the day. So rather than it be consistent time of the day where we can actually compare yesterday against today it might take one between 3 and 4 a.m. and you might be asleep, and then it'll take the next one when you're in the car, and then it'll take the next one when you're sitting in the office. And like Jacqui mentioned before, depending on what environment's happening around us, will have a heavy impact on what our HRV reading might be at that time. So really the only usable way I've found for the HRV on the Apple Watch itself is that trend over time in the monthly or the 6 monthly view.
Okay, great. Thank you. And Louise has commented that the stasis breathing app, so just talking before about the breathing exercises, the stasis breathing app is very good too. So that may be worth looking at. Brittany asked, can the patient download the data to forward the practitioner from these applications?
Usually not, in my experience. Some people will send me screenshots if I'm seeing people, so that's if I'm seeing people via telehealth. Otherwise, we'll have a look at it in real time at their phone in a face-to-face consult. Yeah, there are some that you can pay for, but I think it's something like $40 or $50 a month or something like that. And then the practitioner's got to have a practitioner portal and that sort of stuff. And it just adds extra complexity, unless that's all we're looking at with people, is like just heart rate variability, which is not
Sure.
useful.
Screenshots work well. Somebody else has asked, is there an app for the activity diary? So that may be interesting for everyone on board tonight to know, is there a particular app that you use, or are you just asking people to write and keep a paper record of their activities?
I have a spreadsheet that I send my patients. And the other thing is I've found the app timetable, I think it's called, and only because it's got the right color coding, I've found really helpful for some patients to use. However, some people will like to just use either their Google Calendar or their Apple Calendar, depending on what they've got, whether they're technology based or paper based. I'm an old school paper based person, and I replied to that one. I'm happy to share a copy of my activity diary, which somebody didn't ask about. So I often get my patients to do like the date, what the weather is, because weather's obviously really important, and then their ratings at the start and the end of the day. So patients, I often say you can create your own, you can use mine, you can use your phone. It's really giving them the option as to what is easiest for them to do to gather the data, because you want them to gather the data rather than feel like it's a piece of homework and they can't achieve it.
Yeah.
I have had a couple of people use Dailyo or Bearable as well, for people that really don't like paper, and because you get them as well, Jacqui, don't you, where people just want and prefer to use apps, and they can be modified, those two apps, to be used.
Yeah, absolutely. Okay. Wondering if you two would like to finish up with the case study that you had wanted to present this evening before we wind up the webinar.
Yes. Yeah. Did you want to share the screen?
Yes, I will do that again.
Jacqui, if that's okay.
Just while Jackie's getting that up,
yes.
We didn't have our slide prepared. Sorry for that, but we do want to make you aware that we have set a date for the Australian POTS Foundation Conference. That's going to be the 5th and 6th of April 2024 in Adelaide. So on the 5th of April will be a scientific conference for physicians and allied health. And then on the 6th, we'll have a consumer day where we hope to have a lot of the same presenters, but with a targeted focus towards consumers. So please put that in your diary and we'll get some more information out to you soon as it comes.
So this particular case study here, I guess, just sort of highlighting this person's experience. And I apologise if it is quite vague. They gave consent, but also asked me to keep it quite vague for privacy reasons. So this particular person, in terms of their history, POTS from viral onset, previously, I would say extremely active and a busy lifestyle, ended up housebound post the viral onset, cleared by the cardiologist and neurologist, and advised to do GET, and declined to bedbound afterwards in terms of function, following a very strict GET protocol. Heart rate at this point in time, when this person came to me, was frequently 120 beats a minute plus on standing, so very tachycardic. Heart rate delta, so the change in heart rate from, well, this was more so seated / supine to standing, was oftentimes more than 40 beats a minute. So more than 30 required with something like a standing test to meet the POTS criteria. some hypermobility, and likely some mast cell interaction as well. The doctor advised to trial a non-pharmacological approach initially to POTS management. Some pharmaceuticals were trialled for other symptoms. In terms of the progress, so when we had already, or when we commenced, this person managed to begin very good pacing, and we found that out through activity diary side of things. We did review that a bit more, but this person was doing very well and wanted some structure around movement. An area that we identified was to definitely increase that sodium intake further. So they were intaking some sodium, but we could improve on that, and they were tolerating an increased level well. So they were the upper end, and very consistent with that. And we also added in some lower body compression. We started mostly with the physical countermeasures because this person was bedbound essentially at that point in time, but fortunately getting some assistance with ADLs, plus a few basic bed-based exercises. These were initially things like bridges and side-lying hip, and some calf raise, so some seated calf raise. Initially this person was doing it for a couple of days on and 1 day off, because that was what we identified as being able to have least impact on fatigue. At that point, once we got past that, we did include some heart rate variability, morning readiness, and this person resonated substantially with this and found it provided some useful objective info for guidance together with how they were feeling. Once the heart rate response had improved with standing, we were able to incorporate some standing movement after we we moved through some seated resistance training as well. So some things like some seated calf raises and a seated deadlift, which was this person's, it was actually their sim. So something that they actually really enjoyed and wanted to get back to. So we found a way that they could do it. And then recently we've managed to progress to some standing resistance training. So now to progressing to a standing deadlift and tolerating it exceptionally well. Again, a personal favourite of this person. Initially, we started off with some smaller amounts of walking, and this person had a preference for this over something like a recumbent bike. They just reported every time they did walking that they coped better with it than the recumbent bike, less muscle fatigue in the legs. So we took that step in a very monitored manner, and they've coped with it really well. Initially, it was 2 minutes, often only once a day. And then most recently, I've actually more recently reviewed this person than this slide has been updated. We're now up to 3 lots of 17 minutes per day consistently. And that's been over probably closer towards an 18 to 20 week period now. So in terms of the things that we've really focused on is just that personalisation. So finding that baseline and extremely small progression, oftentimes having to hold this person back a bit. And yeah, seeing their progression over time in terms of particularly their walking tolerance, and now transferring across being able to do more not only of structured activity, but then also improving with things like ADLs too. So it's been a substantial improvement over that period of time. I'll pass back to you now, Celine. That sort of finishes that case study there. It's still in progress at the moment.
Yeah, absolutely. No, that's been very helpful. So I'd like to thank both Caelum and Jacqui for joining us this evening. I'm sure you'll agree that it's been a very fabulous and informative webinar. And just a reminder, that it has been recorded and will be available on the Australian POTS Foundation website. Please keep an eye out on in your email over the next few days, and we'll be sending out an evaluation form, and we always value your feedback, and that does assist us in planning our future webinars. We hope to see you all again on Monday, the 24th of July, where we'll be talking about the pearls and pitfalls of using special diets in POTS. Good night, everyone. Thank you for joining us, and see you again soon.
Thank you.
Thank you.